Thank you for all the participation, doctors. And here, Dr. Arun sir is there for presenting the meeting. Thank you, sir. Thank you, Director. Over to you, sir.
Okay, shall I take on with the discussion right now? Thank you, Team Red Days, for being here to give me an opportunity to discuss in this wonderful evening about the common scenario what we are facing day in and day out regarding dyspepsia, which means some sort of difficulty in your digestion process. Starting from your oral cavity up to the entire GI tract, you may exhibit various presentation. So, what is the background? It's nothing but a characteristic, very common GI condition. Usual presentation will be your epigastric burning. Most of the patients will be exhibiting this kind of events. Next to that, your epigastric pain, early satiety, and your postprandial fullness. I would like to state very simple thing. Any patients who is having frequently will be visiting the primary physicians, followed by the patients will be having worsening of events. At that point of time, the patient will be visited by the gastroenterologist. Why I would like to point out, any patient who is having evidence of epigastric burning, pain, early satiety, postprandial fullness, bloated dust, you need to be cautious. And you need to look into two major etiology. One, whether we are tackling any organic focus or we are tackling a functional focus. We not supposed to forget. See, today my intention to make this topic very, very simple. So you can discuss with me at any point of time because it's a simple topic, but the discussion will be taking on in a huge, huge area in which even one day cannot be enough, could not be enough to tackle all those events. So the most important thing, what I would like to say to you all, we need to see whether the patient is having any organic focus for your dyspepsia. What are the various common organic focus? For example, if a patient who completes age of more than 45 to 50 years old, who presented to us in the background of weight loss, who presented to us in the background of significant weight loss, more than 10% of your body weight, once a patient is having evidence of persistent vomiting, or if the patient is having evidence of bloody vomiting or bloody stools, it could be upper GI or lower GI, or whether the patient is having evidence of persistent prominent bloatedness of your tummy is one of the significant alarming picture. And in case if you are going to see any mass or lump in your tummy, next to that, whether the patient is having evidence of any evidence of gastric outlet obstruction. For example, the patient is hearing some sort of barbarian, some sort of various sounds, persistent vomiting, continuous bloating, and the patient exhibit persistent weight loss. So these are all the characteristic presentation. We should not forget that might be a pointer for your organic dyspepsia. If you're going to think in terms of organic dyspepsia, to assess the etiology, it's very simple. You're going to look at the diagnosis, clinical presentation, alarming picture, do your endoscopy, do your imaging, come to the diagnosis as early as possible, and to treat the conditions pertaining to the presentation. But this organic focus will be more common once a patient turns up older. But in our Indian scenario, nowadays, even younger male patients or younger female patients in the range of 20 to 30 years will be having more of events of dyspepsia. I mean, daily in my practice, I'll be seeing many young patients who, I mean, for example, the IT personality. If an IT person, if you are going to turn to your center, who is going to continuously post-COVID scenario, they have been working in the home and most of the patient will be having burning sensation, epigastric pains, satiety or fullness, and most of the patient will be having more of irritability throughout the complete GI tract. And with this kind of presentation, more they'll be referring to us, even with multiple medication, the symptoms are not improving. And to label them as functional dyspepsia, it's one of the very toughest target for even for the best of gastroenterologists to tackle. Because if you want to label a patient for functional dyspepsia, you need to have a list of battery of huge workup itself. You need to confirm all the basic process, and then only you can able to label them as functional dyspepsia. That's one of the toughest target to assess. What I would like to point out, as per the Rome criteria, if you're going to look into the Rome 4 guidelines, there are huge list of your functional dyspepsia, the gut and brain factors will be involving. If your dyspeptic symptoms is being worsened, you may be having associated coexisting your irritable bowel might be a presentation. So all these things to be addressed when you're going to manage a patient with dyspepsia. These are all very simple things. Always, most of the time, the population will be predominantly in women when compared to the men. And the prevalence almost gone up to 30 to 40 percentage toward the world global population. And the quality of life is going to be having significant impact. I'm talking about the cause of functional dyspepsia. You will list it could be epigastric pain syndrome or it could be postprandial distress syndrome. There is a huge list of target for you to manage as per your own guidelines with your functional dyspepsia. Apart from that, it affects more than 7 to 49% of the Indian population, various studies, and your list of medications, starting from your H2 blockers, your alginates, your PPIs, your list of molecules. Now, PCAS, potassium blockers, so many new molecules being continuously introduced into the market to target this dyspepsia. How to do that? According to the basic guideline of your Indian society, if you're seeing any patients who's going to exhibit signs of reflux, in which your gastric contents, if it is going to refluxate into your food pipe in esophagus, the characteristic event of gastroesophageal reflux disease is going to take on. And most of the patient who is not responding to your PPI, and the patient will be referring to us for basic endoscopic surveillance. And when you're going to do endoscopic surveillance, you may not identify any findings at that point of time. So it doesn't mean that the patient is not having any focus or GERD, because GERD is more of clinical diagnosis, and to look into your clinical presentation with your endoscopy to add on with your clinical diagnosis. If the endoscopy is normal, doesn't mean the patient is not having evidence of GERD. So you need to be cautious. There is an entity called non-erosive reflux disease. In Indian scenario, most of the population, more than 60% of the population among GERD will be in focus of non-erosive reflux. So you need to characteristically identify the patient with evidence of GERD. Approximately 30 to 50% of the patients have additional symptoms of your functional dyspepsia. So always it will be overlapping. Your GERD and your FD will be overlapping, and always you should remember that your dysmotility of your gut as well as your visceral hypersensitivity will be more higher. That's why most of the patient, even if you're going to give the best of medication, will not respond to the treatment. And you need to counsel, you need to control the mind, you need to control the gut, along with you need to overcome the situation. So diet, lifestyle modifications, assessing the patient takes a huge role when you're going to manage a patient with functional dyspepsia in the background of your gastroesophageal reflux. So this is the basic guidelines. You all should remember that once a patient is going to present to us in this background, your belching, your frequent reflux, your acid eructation, your meal associated changes, your stool frequency, if it is going to get changed, you may have epigastric pain. You should remember the basic diagnostic criteria for your irritable bowel syndrome. What are the basic things? The commonest presentation will be abdominal pain, epigastric pain. The patient will be having frequent urgency to go to the toilet. Next to that, the patient may have evidence of a relief of passage of stool. Once the patient is going to the toilet, there might be having evidence of relief, or the patient may have change in stool frequency. Either it be more or it may be less. The frequency of the stool may get changed, or the patient will be having relief with your passage of stool of your varied presentation. So this is the basic diagnostic criteria for your irritable bowel. in the background of your own criteria along with your functional dyspepsia. So tackling your functional dyspepsia with GERD, with your irritable bowel, all these things will be overlapping most of the time. That is why it's very difficult task for treating a patient to identify a patient with functional dyspepsia promptly. So the characteristic presentation will be basically divided into three major things. One by, if you're going to look into the pathophysiology of GERD, there's a separate area starting from your oral cavity up to your fundus, up to your antral region. The main thing what you're not supposed to forget, your transient lower esophagus sphincter relaxation. Once the patient is going to impact accommodation of your gastric region, followed by your TLCRs if it is going to get activated. So what is going to happen? Your fundus relax, and that's the most important thing. And your diurnal eosinophilia, in which if you're going to use H2RA receptor antagonists, and in diurnal hypersensitivity, if you're going to use your PPI or PCAB, potassium blockers. So why I would like to say this is the basic anti-PPIs. Which one is the best PPI to consider for you to manage you very briefly in a precise chat? So you're going to have is from 1980 onwards, the PPI usage being there in the market, and new list starting from your omeprazole to pantoprazole, rabeprazole definitely is going to have a potential role. Now rabeprazole has been introduced at a dose of around 40 milligrams, definitely can be considered. A dual release preparations are there. For example, based upon your off-life, the targeted off-life will be 8 to 12 hours for most of the PPI. So based upon that, you're going to use for various conditions like a GERD, your Barrett's, your Zollinger-Ellison. It's nothing but your high level of gastrin secretion. What do you mean by Barrett's? It's nothing but in case if esophageal squamous epithelium, if it is going to get converted to your columnar epithelium of your gastric mucosa, which means there is high possibility for that kind of patients to land up with evidence of malignancy over a period of time. That's nothing but Barrett's esophagus. And eradication of H. pylori as a part of combination regimens with your various antibiotics. Now, you list of antibiotic protocols are there to consider for a period of 14 days of regimen. For example, your amoxicillin, your clarithromycin, your PPI, amox, metro PPI, nowadays even rifaximin, nowadays even along with levofloxacin. So many new combinations are there for eradication of H. pylori, which is very strong potential risk factor for your peptic ulcer disease. So if you're going to look into your peptic ulcer, the same pathophysiological events, nothing but it would be because of your gastric or your duodenal ulcer. If you know that, the basic things, even with your food or precipitation factors, if it is going to get activated, the source will be predominantly because of your gastric. Duodenal, if you're going to have your food, the symptoms is going to come down. So the most important thing you need to assess, so broad mechanism of action, your extensive metabolization in your liver, for example, by your P450 by 2C19 and 3F4. That is why most of the PPIs will be extensively metabolized. That's why we need to consider the patient with evidence of rabeprazole most of the time, because the metabolism will be less augmented by this process when you're going to use. So the production, the sustainability will be more common in your rabeprazole group when compared to your pantoprazole or omeprazole. So all PPIs have very short off-lives and good oral bioavailability. The most important thing is your Hermes, your esomeprazole, your lansoprazole, your rabeprazole or pantoprazole. So your PPIs are the most effective initial therapy for your dyspepsia. The usual rate of administration will be around 4 to 8 weeks of concentration. Some guidelines mention about your 8 to 12 weeks of concentration, but most of the time, the most potential molecular response, if you're going to give up to duration of 8 weeks, that's one of the most important topics. We're not supposed to forget what are the PPIs you're going to use. Well, I would like to state some significant beneficial role of your H2 blockers, which doesn't contain any major risk factors, major side effects, except for few events like your tachyphylaxis. If you're going to use your H2 receptor antagonist for a duration of time, the risk of tachyphylaxis, which means the response rate is going to come down. Apart from that, in case if you are having severe erosive esophagitis, for example, there is a grading system called lozenges. In that, grade A, B, C, and D will be there. So once a patient is going to be in grade C and D, for example, if it is almost the circumferential involvement of your esophagus, the multiple erosions, if it is going to get happen in your endoscopic finding. So at that point of time, the role of H2 blockers definitely will be less when compared to your PPI. So PPI is going to have a significant beneficial effects in management of your dyspepsia, but among PPIs there are huge list of adverse events also there. As a consultant, I should not talk only in one area. We need to discuss about the benefits. We need to talk about the disadvantages when you're going to when you're going to treat a patient with a different clinical scenario. So to talk about the beneficial role, how rabeprazole is better than any other PPIs, because the highest PK, the pharmacokinetic potential of all PPI, and is least stable at neutral pH, is more rapidly converted. As you all know, the proton pump, once it's going to get accumulated in your parietal cell, it's going to inhibit that. Your hydrogen ion production is going to come down. Your intragastric pH is going to sustainably increase, followed by your PPI is going to have a potential mechanism blocking through your hydrogen potassium ATPase pathway. As we all well know right from your basic knowledge, but it may have a prolonged potency by acid inhibition due to continuous binding to your proton pump transmembrane domains even after achieving your 100% pump inhibition of your ATPase activity. So in all the parietal cells, has not been discussed. If you're going to look into the gastric secretory apparatus, your parietal cells is one cell which is going to secrete your acid. It can be as much as 10 times more potent than other PPIs. It has also been verified that rabeprazole exhibits a potent and rapid onset of action, with the proton pump being almost completely inhibited within fraction of minutes of exposure to the drug. So it mentioned your GERD healing for a period of almost 5 years. And as I discussed, your intragastric pH will be maintaining more than 4 most of the time for hours. So why I would like to point out this, when compared to other molecules, your rabeprazole definitely is going to exhibit a significant potential role. And as you look into this paper, when you're going to use rabeprazole within 100% of potential action of your inhibition of your ATPase, and within a span of 5 minutes, when compared to your Lanzo, Omi, Pantoprazole, in which the duration will be slightly more when compared to that. So the Pantoprazole was the slowest, followed by Omeprazole, as well as your Lanzo, while rabeprazole was the fastest of all when you're going to look into this graph of presentation. So how rabeprazole is going to be better than all PPIs if you're going to look into this study. So when you're going to use your omeprazole at your dose of around 20 milligrams, your Lanzo 30, your RB at 20 milligrams, the significant intragastric pH maintenance for more than 4 will be more when compared to other molecules. For example, your rabeprazole will be having a significant potential role of your action. So this is the basic outline about your rabeprazole. It's a greatest selectivity for the cysteine bonds in your gastric proton pumps. More of theoretical purpose, you should remember that. It is going to convert to your active form rapidly, and significant faster onset of anti-secretory action, and greater degree of acid suppression, and less potential drug interaction. That I would like to say, because you should remember certain things. You should not forget the major acute coronary events. If the patient is going to be on aspirin or clopidogrel, in which the predominant source of action by a CYP 2C19 and 3F4 pathway, at that point of juncture, when you're going to use a patient with the basic PPI, there is high possibility for you to have an interaction with that kind of molecules, and the potential beneficial role of your clopidogrel may go down, and the risk of potential major acute coronary events may go high. So that's why you need to consider rabeprazole for most of the cardiac patients when you're going to manage, because it will not act predominantly through your CYP3A, 2C, 2A4, and all those pockets. So I would like to point out that it has a shorter duration of action and dissociates more readily from your hydrogen potassium ATPase, resulting in a faster rate of inhibition, and it's going to provide you a symptomatic better relief when compared to other PPIs. And to make my point very clear, there are certain papers that to quote the beneficial rate. This study was done in Andhra Pradesh in India. When compared to your basic PPIs like your esomeprazole, rabeprazole is going to have a significant potential role to improve your quality of life when you're going to use at a rate of around 40 milligrams in your moderate to mild to moderate GERD when compared to your esomeprazole dose of around 40 milligrams, and your reflux, your regurgitation, all those symptoms is going to have a significant impact with your rabeprazole rather than when compared to your other molecules. And in this paper, they have been checking the beneficial effect when compared to your pantoprazole, which has been studied on the first day of administration. Oral rabeprazole, as I discussed the same point here, the 20 milligrams dose was significantly more effective as compared to your 40 milligram of pantoprazole in inhibiting your nocturnal heartburn. And one thing you should not forget, nowadays dual release preparation, dexlansoprazole, so many molecules are there, but when you're going to use a high dose of PPIs, you should remember the beneficial role and also the potential adverse events. We should not forget when you're going to target a patient with various conditions. Apart from that, very importantly, if you are going to use H2 blockers in the night time, there is high potential role for you to prevent that NABs. What do you mean by NABs? Nocturnal acid breakthrough. The nocturnal acid breakthrough events will be having a worsening of reflex. Most of the patients will be having in night time. And when you're going to maintain a patient with minimal dose of PPIs in the daytime, and if you're going to add on with your H2 blockers in the nighttime, that's one of the potential mechanisms for you to prevent your nocturnal acid breakthrough, and that's one way to prevent more worsening of your reflux presentation. And in this study, rabeprazole is going to improve your heartburn in the nocturnal events. Apart from that, the infragastric pH, as discussed, is going to maintain more than 4 throughout the day as well as night. So what is the basic impact? Basic things: rapid onset of action, faster rate of inhibition, shorter duration of action, less potential drug interactions, and provides early and better symptom relief. So the impact of practice, very important thing, certain adverse events we should not forget about your PPIs. For example, it may have your electrolyte imbalances, for example, hypomagnesemia and other things. Second thing, there is possibility if you're going to use PPI. I've seen multiple centers for years, they'll be prescribing PPIs routinely. If you're going to use PPIs for longer duration, you may have worsening of your fundic hyperplasia, that's one point here, and achlorhydria. You may have your gastric secretion, acid secretion is going to completely block out, and there is high possibility for this kind of patients to have major acute coronary events, and there is evidence for the patient to land up with evidence of kidney disease, for example, your interstitial nephritis, for example, your chronic kidney disease might get worsened. And second to that, when you're going to use PPI, the huge impact is still happening in your liver. Very interesting to discuss here. The patient, if the patient is going to have evidence of your acute or chronic liver failure, ACLF, that's clinical great scenario to understand the mechanism. If you're going to use PPIs, the rate of worsening of septicemia will be more higher when compared to other things. That's a separate area for discussion. I don't want to point to that now. You should remember what all the beneficial effects are there to discuss about this PPI. Also, there are so many adverse events are there when you're going to use PPI. So you need to be cautious to whom you're supposed to use, under what basis you need to use, what is the basic clinical presentation, how long to use, how are you going to assess the patient response, whether you're going to combine your PPI with prokinetics. In case if you're going to combine your PPI with prokinetics, what sort of prokinetic you are going to use? Whether you're going to use domperidone, commonly available right from day of in the beginning phase itself, or you're going to use your itroprine or cinetroprine, which is slightly higher potent when compared to your domperidone, or levosulfurate, which is being using very frequently, which may land up with other common adverse events for like your extrapyramidal events. All these things you need to address promptly, and to whom you're going to target, whether they're going to target younger population, middle-aged, older population, men or women, body mass, your clinical events, coexisting presentation, various other comorbidities. All these pointers is important. Just like that, adding a PPI will worsen the scenario. You should not forget that. And to talk about the power study, I'm happy to share that I'm also one of the member in India to share this. So this is being mainly been taken over by a professor, Dr. Randesh Sir in India, which is power 1.0 now, 1.2.0 is also happening now. But in this study, what they've been mentioning that, so the findings are Rabeprazole will be having significant beneficial role, and the promising action has been proven in your power study. Apart from that, the perspectives is mainly based upon pan-India study, multicentric, cross-sectional, and questionnaire-based, non-interventional observation study. So if you're going to look into that, the basic results of in 9 months duration among around 3,739 population in across various states of India, it has been proven that male has slightly more preponderance than female, and urban has slightly more preponderance in rural areas. And the commonest age group will be in the range of 30 to 40, and dyspepsia being involved for a duration of 12 months, 6 to 12 months. And function dyspepsia patient will be usually less than 40 when compared to your organic focus more than 40. And gave issue of usage of alcohol and tobacco, most of the study population will be involved in that. So in this study, we have been proven that Rabeprazole is going to have a significant beneficial role when compared to a 66% when compared to your esomeprazole of around 8%. And Rabeprazole, the most frequently used PPI among patients who consumes alcohol or tobacco with different comorbid illness. So in this paper, what they've been pointed out by Power Study, the proportion of patients answering completely about various questions, if you're going to see, most of the patient will be exhibiting the high level of satisfaction with your Rabeprazole when compared to other molecules in this huge list of questions in which you have been derived from the patient. So patient satisfaction is important, less of adverse events. You can consider with less of potential drug interactions like your clopidogrel, and when compared to your adverse events, among them, Rabeprazole definitely to be considered in the higher potential and longer safety and better bioavailability and long run. Now Rabeprazole being available at a dose of around 40 milligrams and higher degree of responses and mucosal reeling definitely been well accepted when you're going to use Rabeprazole. But certain things we are not supposed to forget. Symptom relief is going to be more better, cost effectiveness will be more better, overall patient satisfaction will be good, your rate of medication adherence and convenience of therapy will be good. To sum up, never forget dyspepsia, very common presentation. Worldwide prevalence will be more than 20 to 30. Rabeprazole definitely will be having a potential role in power study. Happy to be associated with that. In that, we have been proven Rabeprazole will be having a significant beneficial role when compared to other population. But always you should not forget usage of patient to whom you are going to target, whether you're going to treat peptic ulcer or whether you're going to treat reflux pathology or whether you're going to treat a coexisting other complications or diabetic gastroparesis with your PPI or example with your prokinetics, or in the various scenarios you should assess the basic nature, confirm the patient through endoscopy and manage the patient successfully if you want to overcome this complications. But one thing, diet, lifestyle modifications supposed to be aggressively analyze the patient's status. We need to counsel the patient on diet and lifestyle modification, frequent small meal, and sleeping, no avoidance of sleeping in the prone position, and avoidance of food in late night, better finish up the dinner before 7 p.m. in night, and always go for avoidance of high fatty meal and avoidance of high carbohydrate based diet. All those things with good physical activity, at least of our own, and prevention of your fatty liver, control your diabetic, control your hypertension, all those things, control your thyroid status, control your obesity, all those parameters to be taken into account when you're going to manage a patient with dyspepsia. With this, I'm happy to rest my presentation. Thanking you all for patient listening. And if any questions are there, I'm happy to take on with you all right now.